Thank you, Krishna. That was wonderful. And thank you all the panelists. We have slight change of sessions here, and we probably going to have debate initially. And the debate will be very interesting on use of chemoimmunotherapy versus chemotherapy in PDL1 negative subtypes. And for the motion, Dr. Prabhat Singh Malik is going to talk, and against will be Dr. T.P. Sahoo. And at the end, Dr. Govind Babu sir will give the verdict. So let me invite Prabhat over here.
So, very good morning. And thanks to the organizer for inviting me here for this interesting debate. Actually, when I looked at this topic, chemoimmunotherapy versus chemotherapy in PDL1 negative and non-small cell lung cancer, these were my reaction. I mean, why we are having this debate in 2024? We have enough data now, but since it's a season for debates, it's time for elections, and it's good to have debates. And as we are growing older and probably more mature, like my opponent, Dr. Sahoo, and so the data of many of these studies is also getting mature, and we have much more better results and much more better understanding. And the irony of the day is that a person is speaking about for immunotherapy who barely use immunotherapy is in clinical practice. On the other hand, a person who barely use chemo alone is going to fight for chemo. I mean, it's interesting, but that's how it is. So let's start. I will start with a case. A 65-year-old male ex-smoker diagnosed to have metastatic non-small cell lung cancer, adenocarcinoma with metastasis to both lung. There was some skin or subcutaneous nodules, asymptomatic brain mets, good performance status, and PDL1 TPS, this is tumor proportion score and not Dr. T.P. Sahoo. This is less than 1%. And these are the NGS result. I mean, that's what you would do for any patients before deciding on treatment. This patient do not have any targetable driver mutation. Interestingly, have two single nucleotide variant in TP53 and one indel in NF1 gene, where both of them are not targetable. Interestingly, this patient had a high tumor mutation burden, which is 15.8. So what would you do for these patients in your clinical practice? So obviously, Dr. Sahoo, if you say chemotherapy alone, probably these are going to be the reactions for most of the people sitting here. And I think chemoimmunotherapy would be the yay moment for everyone. Obviously, I have intentionally put that. And those disclosures I have already put in the beginning. So, I mean, that's how we make therapeutic decision in today's time. We look at the histology, we look at the targetable driver alterations. And after that, I think PDL1 is something which help us in deciding about use of checkpoint inhibitor. But to the best of my understanding, I may be wrong, Dr. Sahoo, but I think it's the absence of driver mutation, which probably is the best predictive biomarker for immune checkpoint inhibitor. PDL1 has its own issues, but yes, it is there because that's doable. And obviously, we should not forget the patient-related factors. What are the preferences and goal of treatment, overall general condition, and other comorbid conditions. So this is the current treatment paradigm, how you look at patients who are negative for driver mutation. PDL1 does help you, like if you have a person with high PDL1, you can use monotherapy. A combination with chemotherapy or an IO-IO combination or IO-IO chemo combination is there for patients with intermediate and no PDL1 expression. And for PDL1 negative patients, this is the level of evidence. You have number of studies where people have used various combinations and which have shown clearly better overall survival as compared to chemotherapy alone. Be it a IO-IO combination, checkmate 2-7, or a checkmate 9LA approach, or Keynote 189, the landmark trial of pembrolizumab with chemo, and never forget IMpower 150. So this is where this story started. A couple of years ago, we had this study called Keynote 189. And there's no doubt about the positivity of this trial. This is a clearly positive trial. It showed significant improvement in overall survival when you compare it with chemotherapy. And yes, PDL1 makes some difference, but even in PDL1 negative, if you look at the subgroup, if you are very fond of looking at subgroups, even patients less than 1% are getting benefit in terms of overall survival. This is again, the magnitude of benefit certainly is driven by PDL1. I completely agree with you what you're going to say. That if you have high PDL1 expression, these patients derive more benefit, but even for negative PDL1, when you're using it in combination, there is certainly the benefit is there. And as I told you in the beginning that we are growing old, and so the data is getting mature. And even after 5 years of follow-up, you see the difference in terms of overall survival is maintained, even in patients who have PDL1 less than 1%. And the same thing is reflected in progression-free survival. You have mature data of Checkmate 227. Again, whether it is PDL1 more than 1%, less than 1%, these patients who are treated with these combinations are living more as compared to chemotherapy alone. Similarly, for Checkmate 9LA, you see probably doesn't matter much whether it is PDL1 less than 1% or what histology you are seeing. And probably even for Checkmate 9LA, you have 3-year follow-up, and it seems that PDL1 is not making a big difference here when you are using these combinations. What making some difference is probably the type of mutations they have. KRAS mutant probably getting more benefit as compared to the KRAS wild type, and P53 mutated patients are getting more benefit as compared to the wild type. And STK11 mutants, which are classically considered as immune-resistant cases, these patients also seems to be deriving some benefit with this interesting combination. One subset where I would strictly go with you, Dr. Sahoo, and would avoid using immunotherapy would be a subset having a targetable driver alteration, and we have sufficient evidence to suggest that. And it's not only the lack of efficacy, but concerns about future toxicities. So that is something I will keep in mind. And I'm sure you would be talking about the cost effectiveness. Unfortunately, in Indian context, whatever molecules, I mean, if we talk about cost effectiveness, this conference would be closed today itself. So 90% of the content which we are talking is not cost effective in Indian context. So what people have done analysis abroad, at least in United States context, this combination, when you are using Pembro with chemo, this combination seems cost effective. And PDL1 segregation is not making any difference in terms of cost effectiveness. So I think I rest my case here, and with the statement that for PDL1 negative is either IO-IO, is chemo-IO, or IO-IO chemo combination. And I would agree with you partly that PDL1 negative cases, we are still not there where we want to be, but chemo alone certainly is not enough, and I think we need more. Thank you very much.
When you have, friends like our good friend sitting down, why do you need enemies? Huh? So that is the first statement which I'll make. But Prabhat, you felt that it will be a cakewalk. So let us see what it is now. So my thing is based on rational, efficacy, toxicity, financial toxicity, and the finances involved. That cannot be taken out of any context, that all of us know. And the cost-benefit analysis, I'm sorry, I'll bring that in. And we have the data set also otherwise. So rational, all of us know that these are targeted treatments, monoclonal antibodies, and this would be having a target. And if the target itself is missing, then science is wrong somewhere. That is one point. We either accept it, there is no science in the PDL1 story, and then we rest here. And if there is some science, and that science you showed, that yes, more than 50% it works very nicely, in one it does not. So there is science to it. So if you don't have that target, why at all then do it? And if you want to prove it further, if you go beyond lung, take the case of cervix itself, and there is not only cervix, I can go on and on this, that if it's a PDL1 negative, it really does not make any sense. And now we will have data set now on lung cancer. And now we'll have the efficacy data set. I'll first come to, there are 4 or 5 trials actually, because it was a frontline debate. And if you look into the Empower Lung 3, which is a semiplimab plus chemo versus chemo alone, and this is why I put this up very clearly, is this is one of the rare frontline trials which had a stratified factorization put into less than 1 and more than 1. So this trial was powered to look into that. So this is one trial, that is why I put this trial up. And if you look at the intent to treat, it was a positive trial. But the story starts, who are the best patients whom you should be offering this thing at all in a PDL1 negative. And if you see that story, and this graph really gives it away, all the subgroup, and look at the PDL1 less than 1, and mind you, and the numbers are equal in all subsets. So this is not that something that is powered probably. A stratification was done earlier, and if you look at it, the hazards is sitting right in the center. So basically this group does not benefit. And this is the OS data that has put into, that was published few months back. And look at the numerical part of it, and look at the OS, and if you look at the less than 1%, and look at that, the combination of the immune checkpoint and the chemotherapy had 12.8 months versus chemotherapy alone of around 14.2 months. So I'm spending more for a lesser survival. If that is how your patients start choosing, then I think I will also rest my case here, because this is where it all stops. That I'm giving something that is costly, but I'm going to live lesser, and I'll be having more toxicity. So the bargains are all in this way. Now let's move little forward. एक trial है. Let's see some other trial. By chance है ये तो story तो वैसी होना चाहिए. So I go to Keynote 407, which you purposely did not mention. And let's see what Keynote 407 points out. And beautiful diagrams, which is again showing something that is being shown in the Empower 3. Look at the last D, which is the survival curves for the combination of Pembro plus chemo versus chemo, and look at the 5-year OS. Numerically lesser likely that you will survive the 5 years if you have taken immune checkpoint upfront. So this is your chance of getting and living lesser at a particular point with even pembrolizumab if you are squamous cell carcinoma positive. And 189, you yourself told and very clearly that the graphs are looking closer and closer, although it holds its statistical value. I'll take it and concede that, and in non-squamous. So this is point number 2. Look at IM power. The story really gets very interesting if you look at IM power 130 and 150. Sorry, 150 somehow was lost. I pasted it, but it did not. But I will after the debate put it in the medical oncology group, the IM power subset analysis for the OS. And this is the 130. This data set again shows that for OS, the PDL1 negative, it was statistically insignificant. And IM power 150 is furthermore bad, and this actually is sitting on right on the middle. So I showed 407, the Empower 3, IM power 130, IM power 150. 4 out of 5 data sets, except for 189, showing little bit that, okay, I have to give him something now. So 189 is something that is showing, okay, it might work, but rest every 4 out of 5 data set in the front line is telling you it really does not work if it is PDL1 negative. Now come to toxicity. So you are giving something that does not have a target. You are giving something that is efficacy-wise inferior. So what at what cost? And if you look at the toxicity, look at the Empower 3 again. And if you look at it, grade 3 is something that I ask all my friends to always look into. All grades will be all similar. But more than equal to grade 3 is something that matters to the patient. And look at it, 48% versus 32. And lead to discontinuation is double. But this data set pulls across everything. Just look into how many had to discontinue a combination, and you will see that in nearly every trial it is double the chemotherapy discontinuations. And more number of grade 3 toxicities apart, more double the patients will discontinue if you are on a combination for something that is potentially probably not adding anything to what chemotherapy is adding. yes, if I have to give something, this is the probable regimen I'll go to in a PDL1 negative, the IO plus the chemotherapy. This is something which we can sit across the table to agree upon on a consensus basis. Election years, you give some, I give you some. So that is how it should be. So it's a coalition government. So this is where the coalition meets. IO and chemotherapy, probably numerically, especially in the squamous cell variety, has shown the best possible results. And this is probably where I will again concede little bit. Otherwise, it is nothing but chemotherapy. Look at the cost and the financial. I put forward, and in the last 1 minute, the reality will punch all of you. We are a rich country, the 5th largest economy, going to be the 3rd largest economy, maybe. But this is the reality, and today, tomorrow, when you go back to OPDs, this is the reality. The per capita income, which I last saw in India, was 1,70,000 rupees going to 2 lakh rupees. This is not per month. This is per year. So a family on average per person earns 1.5 to 2 lakh rupees, and this is an unequal distribution of wealth. And look across the states, most of the states will look the red and the not so red. Means these are much poorer states having a per capita income of around less than 1 lakh rupees. So they only earn 8,000 per person, leave the expenses apart, and we in the 2018 Global Multidimensional Poverty Index were equaling Nigeria, Ethiopia and Bangladesh and others. So we are still going ahead and trying to reach that status. So what does it cost per annum? 8 to 10 lakhs with these support programs. I've taken the support programs, I'll take a minute. Chemotherapy 60,000 to 2 lakhs for the 6 cycles and the maintenance if you want to give or don't give. So this is the chemotherapy from a government setup, non-MRP to MRP based. Hospital expenses will be 20,000 to 1.5 to 2 lakhs to 3 lakhs depending on the hospital which you take. The toxicity will be 30,000 per 1 year, I've told, to anyone's guess. If he lands up in a hypophysitis to anything else, I think we have our friend Ankur and he will tell you how much that cost. He showed us a case report 2 years back and it cost in 30-40 lakhs to take the patient out. And miscellaneous expenses around 30,000. So I calculated for an immune checkpoint inhibitor, it is anything from anywhere from 8 to 10 lakhs or 12 lakhs in a minimum to 30 lakhs or more beyond depending upon which you have to spend, mind you, for nothing. That is most important. So are you having second thoughts, Prabhat? That is the question I have to ask you now. And I end off with a cost benefit analysis. This is the US and this is the China. The bold yellow line which you can see is something the patients have to pay on this cost, and the line straight is something the patient is willing to pay on that which just do the statistics. You will see even for all comers, it is not effective in US also. More than 50% or more than 1% is something it looks okay. In China, nothing is effective. So in India, I assume you know what is effective then cost-wise. So with that, and if you look at how they concluded, using PDL1 test for patient selection, and companies listen, the price reduction also was important. These two only could make it cost-benefit analysis an important drug. And this happens once you do not look at PDL1 and start building bridges. This is where the bridge will land up. The other person will be here and the other one will be here, and they do not meet each other. So, friends, for PDL1 negative, I rest my case and I hope I've given you enough data set to not let your patient go through the financial and toxicity torture, and just give him the chemotherapy and reserve immune checkpoint for second line. Thank you.
Prabhat, so you have, you can agree to disagree or you can form the coalition.
No, I usually agree with Dr. Sahoo, and I really appreciate his effort. I mean, so much effort he had to put to, complete his 8 minutes, although he exceeded time. And that again reflect the amount of data he had to show here. So he really had to struggle to find out those subgroup analysis to make his case. So, but the point just I wanted to make on, the problem is probably not the drug or the combination. And if you go by scientific rationale, the combination have a sense. The problem is the biomarker. And all of us would agree that probably PDL1 is not the perfect biomarker. So when you draw these lines of 1%, less than 1%, or more than 50%, you have to consider a lot of other factors into consideration. I do agree that PDL1 completely negative tumor which is completely immune cold and or have some other driver mutation or some other genomic alteration which confer resistance, probably these patients may not benefit that much. I agree, but the combination certainly makes these immune hot environment, and these patients tends to do better, because with chemotherapy alone we have already reached to the plateau. Thank you.
Both aspects of the topic, and both of you did a great job. And as Ankur said, PDL1 is not a target. And as you mentioned, we don't have a perfect target. We know that patients with PDL1 positive also don't respond. And in some patients where I have used in desperation, where PDL1 is negative, they responded beautifully. So that continues to stay. Of course, as Prabhat mentioned, that cost should not be discussed for science, but you are in a real world, so ultimately that has to be discussed, because tomorrow when you go, you're going to treat your patient who is going to pay for the drug. But we have come a long way in treating non-small cell lung cancer. Just to give you some data, in 1990, the American College of Thoracic Surgeon members were asked that if they were diagnosed with stage 4 non-small cell lung cancer, how many would take treatment? And that time it was 15%. The same survey was repeated in 2022, and the number jumped to 80%. So I think we have come a long way, and from nihilism to a good thing. But I think these debates are great, because all of us get to listen to the real positive thing and the real negative stuff. So thank you very much. Yeah, exactly.
So,
when two people are arguing, there are two sides. The truth is in between.
thank you, Prabhat. Thank you, Sahoo, for making it very interesting. I really enjoyed your debate.